2010.
Yeah, it has been a routine.
Okay. So in the US, they recognized that the old algorithm was not doing anything to cope with the number of new infections per year, 56,000 new infections per year. And so they wanted to move away from risk-based testing and implement a new algorithm. And the intention was to reduce the time to result, the cost, and accuracy. So this is the algorithm they choose, a fourth-generation assay. And then the Western blot is a discriminatory Western blot which detects both HIV-1 and HIV-2. And if negative, which could be acute infection, they go to nucleic acid testing. And then if positive, this confirms the acute HIV infection. Okay, so you've got one assay here, two assay. If this is positive, you immediately diagnose the patient. If negative, you go to NAT, third assay, then you diagnose the patient. Okay, so at most, two assays, three assays to diagnose the patient. So what they found, the CDC, when they implemented it, in 37,800 subjects, they identified 55 acute infection cases, okay, compared to the previous algorithm. When they looked at the workflow before the assay was implemented, here, the majority of tests took more than 2 workdays to report a result. After implementing the new algorithm, the vast majority of assays took less than 2 days to report a result. Okay? So the key changes here, they adapted the algorithm to identify HIV-2 infections and acute infections here. So the priority is on sensitivity. So they will have false positive results, but the discriminatory blot and NAT will help resolve that. Okay? So that covers HIV. So shall we have a quick discussion about HIV before we move on to hepatitis C? Yeah? Okay?
You think that the economics of the country in which the government adopts a policy plays a role in doing the tests? Because ideally, if we say that the antigen is the first to be detected in the blood, and if a person gives a history of exposure, sexual exposure, and comes to the pathologist saying that he or she wants to know whether there is HIV, in such cases, when they are asking the pathologist for a consultation and direction, do we recommend an antigen instead of an antibody, or do an antibody and then do an antigen? What would you say?
So there are combination assays available on the market now which react with both antigen and antibody. Our ARCTECT assay, we've got separate microparticles, one population to capture antigen, one population to capture antibody. And ours are not the only assay that does that. If you have a prevalence of HIV which indicates a high level of transmission, uninterrupted acute transmission, you definitely should consider using a combination assay rather than antibody-based. The antigen, you can use antigen-based, but those tend to be older generation assays, and that might have been made using viral lysate and they haven't updated it. Yeah. If it's an FDA-approved assay, it's likely one of those old.
So what is the sensitivity for the combined assay?
Our one, so for the ARCTECT, against many different subtypes of HIV, the lower limit of detection is about 2 IU per mil. Actually, that's the European standard for an HIV assay. You must be able to detect 2 IU per ml. We can detect far less than that, down to 1, depending on the HIV subtype. So you have to consider what subtype you have in your country, because most of the assays are generated using subtype B. They're all made in the West, which is subtype B is the dominant subtype there. Okay?
Instead of going for the going for HIV antigen during the winter period, HIV RNA PCR would be ideal, don't you think so?
It would be if you can afford it. So right now, there aren't many countries which use RNA alone for screening. But if you can afford it, you can.
It would be confirmatory during the window period instead of going for antigen.
Well, this is a difficult thing because you can't confirm the RNA. If it appears before the antigen and antibody, any subsequent assay will be negative. So how do you confirm the RNA? How do you know it's not a false positive?
So what would you say is confirmatory during first 8 days? How would you say what is confirmatory test within first 8 days?
The first 8 days, RNA may not appear before day 9. So you have to ask the patient to come back. And then...
Minimum how many days?
Minimum for appearance of which marker? Antigen. Antigen may be day 16, 17. Antibody day 22.
What is the role of proviral DNA?
Proviral DNA is when HIV integrates into the genome, the chromosome of the CD4 T
How would
cell.
it help in the diagnosis?
So that's, you have DNA, proviral DNA, and you have RNA. However, your viral load tends to be much higher than your proviral load in early infection.
So you say HIV RNA is better than doing a proviral for a window period.
Correct, because there'll be far more RNA copies than DNA copies.
Okay, thank you.
If the RNA is positive in the very, very early stage, how do you confirm it? There's no way out.
Correct.
So you have to wait and watch.
Correct. So this is
Yeah.
why people don't use RNA as a frontline assay, because you can't confirm it. If you wait, and again, what's the difference between waiting to test at day 17 or day 25 compared to day 9? If you wait for day 17, you can confirm the P24 with RNA. If you wait for day 22, you can confirm the P24 with antibody and RNA. But if you do day 9, can you say it's not a false positive on RNA?
So what do you advise? Do you wait for some time?
This is dependent on when the patient presents himself for testing. Because when clinical symptoms occur, again, it may not be at day 9, it may be a bit later. And again, we know different HLA.
You know, we do have patients who come to us directly after an exposure. It's in the next day
Most
or
of us
2
are
days.
private pathologists.
Private
Patient
pathologists.
walks in.
Yeah.
And they just tell us
Yeah.
they had an exposure. So,
After the exposure.
and they're so anxious that, you know, if you tell them 21 days, they'll probably go to 2 other pathologists and get the test done.
So that's the thing. To really be confident in diagnosing it, we do recommend after 2 weeks, 2 to 3
The
weeks.
thing what we do is, even if we are doing it on day 1 when he arrives, and if the report is negative, we tell him this report is negative for any old exposures, maybe 15, 20 days prior to that. So you have to come after 20 days.
Sure,
It's more of a medico-legal aspect.
sure.
So repeat after 3 years.
Yeah.
And what is longest window period?
The longest window period? I mean, this is with our assay. So our antigen, we usually detect at day 16. RNA around day 9. So you can see there's a 1 week difference between that. Not all assays are equal. So other fourth generation assays, their window period may be longer than ours.
So ideally, which is the best assay to use?
We advocate using screening with a fourth generation assay if you have the infrastructure, if you have the capability. Again, it's around 17 days. Yeah, so, yes.
Generally, in our country, we use pre-operative HIV testing as a mandatory thing. Suppose it comes indeterminate. What do we tell the surgeon? What do we tell the patient? Because operation is already planned. Now, there are 2 situations. Once it is not emergency operation, where they can try to postpone it for 15 or 17 days, as you say. But if it is emergency emergency operation. Today we are telling them consider as positive case and take your precautions to operate. But what are your takes on this kind of situation?
Again, we would hesitate to make any diagnosis without firm confirmation. So our architect assay, if it's reactive, we always say, if it fits the clinical picture, you must confirm with a Western blot or RNA. So if the Western blot is not giving you a result, you have to go for nucleic acid. And if you don't have nucleic acid available, either you have institutional guidelines on how to assess the risk of proceeding. So, yeah.
Question is immunity operation.
Yeah.
Then you have to take the precautions. Whatever precautions the surgeon has to take, the universal you take.
Yeah.
That's what we tell them.
And I would ask if the difference between an HIV positive and HIV negative patient for surgery, does the surgeon behave any different?
Ideally, no.
Ideally. There you go.
Okay. Psychologically.
Yeah. I would treat everyone as infectious. Yeah. Okay. Yeah. Shall I move on? Okay. So now we discussed about transmission during the acute infection period before seroconversion antibody. So let's look at hepatitis C, because the majority of testing for hepatitis C is based upon measurement or detection of antibodies. Now, this is the biology of infection here. At day 0, you're exposed, and seroconversion usually occurs after day 60, so antibody comes up here. Okay? So if you're basing hepatitis C testing purely on antibody, look at this seronegative window here from day 8 to day 60. You are infectious in that period. So the first generation tests measuring antibodies here, IgG, second generation, again improved the IgG, third generation IgM. Okay? Now, RNA comes up early. Our upcoming hepatitis C core antigen assay comes up as early as the RNA, give or take 2 or 3 days. Okay? The window period is much shorter with RNA compared to HIV. Now, if we look at the algorithms that have been endorsed around the world, they begin with the HCV antibody as a screen. If reactive, they confirm with nucleic acid, because the Reba test has now been discontinued. It's removed from the market. Okay? And then if reactive, it's diagnosed. If not detected, then it's either a false positive, which does happen with an anti-HCV antibody, or they suggest additional testing. Now, what we disagree with is that if the antibody is negative, they would suggest to stop testing. So based upon this serological chart here, does it make sense if you're antibody negative to discount hepatitis C infection?
No, you have to wait and repeat it.
So you either wait to repeat, and I would say that for our HCV antibody assays, even if they are reactive, the false positives, if they're below a certain level, you can be guaranteed most of these are negative